after the uh, Diwali, we had stopped this session. So today we're going to restart it. This time is given wrong on that. So today we are going to take 6 topics, and these are important for the funnel FRCA, and some other are useful for the primary as well. So the first topic is on potassium, second on humidification, third on TAS, fourth on substance use disorders, fifth on post-thoracotomy pain, and sixth one on liver. So it contains combination of the usual, basic sciences and anesthetic topics. So the first question is on potassium, and like the new CRQ pattern, there are a number of bits to it. So the first question is, what is normal serum potassium concentration, which is an easy one, and what possible etiologies might consider in patient with hyperkalemia. If potassium is administered, how much should be given, how fast? That should be easy as well. Then what are the ECG changes associated with acute hyperkalemia? How would you treat a patient with acute hyperkalemia? This everybody should know. And how much glucose insulin should you use in treating adult with significant hyperkalemia? So a very clinical question. So now, unlike what I actually talk about, how the slide should be in the normal PowerPoints, this is against that. But the reason why these are actually not my normal slides is that the most of the material, the answers are like should be basically on a Word document rather than on a PowerPoint. But and if they are there, then people will be able to read it later on as well. So as far as normal potassium levels are concerned, normally around 3.5 to 5 milliequivalent per liter. Some books would also say that even 5.5 milliequivalent per liter is normal. And we know that potassium is basically intracellular, so only 2% of potassium is extracellular. So when you actually get hypokalemia, then basically represents that there has been a significant potassium depletion in the body. So this potassium depletion can occur by losses from the GI tract. Okay, it could be through diarrhea, it could be through vomiting, through renal losses. It could be because of transcellular shift, so shift into the cells, or inadequate intake. So gastrointestinal losses could be because of diarrhea, because of overuse of laxatives, or it can also occur in acute or colonic pseudo-obstruction. So losses through the NG tube can also be a cause in these patients, or into the bowel itself. Renal losses, the commonest cause is use of diuretics, especially the loop diuretics. It can also be seen in some form of renal tubular acidosis, like type 1 and type 2 as renal tubular acidosis. Then, as the transcellular shift can occur because of the use of beta-adrenergic agonists. So patients using, say, salbutamol regularly, so in asthmatic patients. It can occur because of the use of insulin. So we know that insulin is used in hyperkalemia. It can occur because of patient being alkalotic, so elevated serum pH can cause it. The patient, pregnant women who are receiving tocolytic therapy, and that again are beta agonist, or patient requiring anaerobic support, again because of use of beta agonist, can also cause drop in the potassium levels. Low intake can also cause hypokalemia. It is seen in malnourished patients, but it is usually associated with other electrolyte imbalance as well. So it won't be hypokalemia on its own. It will also present with other imbalances. So talking about treatment of hypokalemia, so every 10 milliequivalent of potassium you administer, this increases serum potassium by only 0.1 milliequivalent per liter. So if the patient has got a drop in potassium of, say, 1 milliequivalent, you would actually require around 10 hours to treat that. So if you're using infusions, then if you have a central line, then you can actually give 20 milliequivalents per hour of potassium. But if you are using peripheral line, then dilute solutions are used, and it's better to only use 10 milliequivalents per hour through peripheral line, because we all know that potassium is very irritant, so thrombophlebitis is very common. Now, if the patient has only got mild and asymptomatic hypokalemia, then oral potassium can also be replaced. And oral potassium, this is usually 40 to 60 milliequivalents per mouth, 1 to 4 times per day. And usually no more than total dose of 100 milliequivalents per day should be given orally. So what about hyperkalemia? This is a lot more dangerous. Um, so we know that hyperkalemia can lead to decrease in resting membrane potential, which can cause hyperexcitability initially. And then later on, with severe hyperkalemia, there's reduction in conduction velocity. Hyperexcitability decreases in severe hyperkalemia. And this occurs because hyperkalemia causes inactivation of the sodium channels as well. So we all should know the changes that are seen with increasing levels of potassium. So as the potassium level increases, the first thing you see is tall T waves. Okay. And there is shortening of the acute interval, and there is then prolongation of PR interval. As the potassium increases further, there is P wave flattening, and there is progressive widening of QRS complexes. And later on, this can lead to sine wave appearance, ventricular fibrillation, or even asystole. So hyperkalemia can be life-threatening in patients. And hence, working classification of severity has been designed. So severe hyperkalemia is when the potassium levels are more than 8 millimoles. There are marked ECG changes, and this requires immediate treatment. Moderate is between potassium of between 6 to 8 millimoles per liter without marked ECG changes. You can still see tall T waves with these changes, but it's not as marked as you see with severe hyperkalemia. Mild hyperkalemia is 5 to 6 milliequivalents per liter, millimoles per liter. And in these cases, immediate treatment is not required. So you look for the cause and you treat the cause. So what exactly is hyperkalemic emergency? So signs, clinical signs or symptoms of hyperkalemia, which lead to muscle weakness or paralysis, cardiac conduction abnormalities, and cardiac arrhythmias is a hyperkalemic emergency. And so this is seen in severe hyperkalemia, wherein potassium is more than 6 milliequivalent per liter. And you can also see it in moderate hyperkalemia with serum potassium of which is 5.5 milliequivalent per liter, where there is significant renal impairment or there is ongoing tissue breakdown, like rhabdomyolysis, or there is increased potassium absorption. So there is progressive increase. There is progressive increase in potassium is seen with these cases. So if you have potassium more than 6, you look whether there is ECG changes present or not. If there are ECG changes, then you need to treat it immediately. And for that, you would give calcium, which is a physiological antagonist, and bicarb to actually treat or drive the potassium in. And if there is no ECG changes, but potassium is still high, then you can use beta-2 agonists like salbutamol and NABs along with glucose insulin infusion. Now, despite the treatment with glucose insulin or salbutamol, if potassium now is less than 6, and in that case, you can actually use risonium or increase the losses by giving patient furosemide, so that increased losses of potassium occur. If the potassium is still persistent, is not reducing below 6, you can actually continue on the glucose insulin. And if it is progressively increasing above 6, so whether that's because of breakdown or tissue breakdown, or it is because of increased absorption, then you might actually also have to consider dialysis, especially if the patient is becoming asymptomatic. So how do we use glucose insulin? In glucose insulin, you 25 grams of IV dextrose, that is 50 mLs of 50% dextrose. To this, we use around 5 to 10 units of insulin. And this decreases potassium to about 1 to 2 millimoles within 30 minutes. And these effects can persist for 2 to 3 hours. So it gives you time, buys you time, so that you can find out what are the cause, or if you need to actually think, what's going to happen with the patient need to be moved to higher center or intensive care for dialysis. And you can always repeat the dose. And obviously it works by redistribution of potassium. It drives the potassium intracellularly. It does not lead to increased excretion of potassium. It's just moving the potassium from your extracellular to intracellular site. So it is a transcellular shift of potassium occurs with glucose insulin. So if you actually look at it, so I was telling that, but if you actually have to classify the answer, you use intravenous calcium to antagonize the membrane actions. So that is the physiological antagonist. You use intravenous insulin with glucose to drive extracellular potassium into the cell, so transcellular shift. You can rapidly remove potassium from the body. This can be done by using diuretics. Okay, it can be used by using a cation exchanger or by hemodialysis. Treatment of reversible causes, all of hyperkalemia should also be instituted. So correcting hypovolemia and discontinuing drugs that can increase serum potassium, example are ACE inhibitors or non-steroidal anti-inflammatory drugs. And it's important that these patients are continuously monitored. Hence, these patients should be shifted to a critical care unit. And serum potassium is monitored at 1 to 2 hours after initiation of treatment. And because you might be using glucose insulin, you need to monitor the glucose as well during the treatment phase. Now, coming to the second question, it's about humidity. The first part is about defining absolute and relative humidity. These are definitions, and they're very obvious. Absolute is absolute, what is there at that present. Relative has to be in relation to something. Okay. And what are the consequences of inadequate hydration and overhydration? List a type of humidifiers which are available, and what are the characteristics of an ideal humidifier? So this looks like a basic size question. So like I said, absolute is absolute. This is the mass of water held in a given volume of gas. That is absolute humidity. Whereas relative humidity is the amount of water vapor expressed as percentage of the amount which the volume of gas could hold at the same temperature if it was fully saturated. So it's in relation to full saturation same volume. So that's why it's relative humidity. And most time we actually talk about relative humidity, 40%, 50% relative humidity. Okay. So this is a nice diagram of showing the your epithelium with the cilia, columnar epithelium, the mucous cells. Okay, so we have the gel layer, which is the yellowish one on the top, and we have the sol layer, which is the water content. Okay. And the blue line is the water content. Okay, that's sol layer, and that's the mucus layer. Okay. So inadequate humidification, when there is not enough of the the sol level will actually go down, and this can lead to destruction of cilia and damage to the mucous glands. And this can be disorganization or flattening of the pseudo-stratified columnar epithelium and cuboidal epithelium, which is actually seen in the respiratory mucosa. It can also lead to disorganization of basement membrane. Okay. So there can be cytoplasmic and nuclear degeneration. As you see, the nuclear cytoplasmic degeneration can occur, which can lead to discommission of cell. And there can be mucus ulceration, and there can be reactive hyperemia following the damage, which can be seen below the cell. Okay. What about overhydration? So this is probably more common in intensive care, where we have actually not made sure that the temperature setting on humidifiers is adequate. So it would normally not occur in usual conditions. So mucosal heating and burns can lead to pulmonary edema and airway stricture formation. And like I said, this is actually only a complication of heated humidifiers. And this only happens when there's been a malfunction with the humidifiers. Otherwise, it should not normally happen. They are in a well temperature control. We do not allow the temperature to go above 40 degrees. And even if the gas is humidified, they cool down in the circuit before they actually reach the patient's airway. So if inspired gases are not heated, but large amount of water administered to the respiratory tract, right? So this is not possible, usually not possible to do that. But if cold, water like nebulization is done to the airway, or installation of saline or water is done directly into the trachea, then this can lead to fall in temperature, and because the body will try to heat it up, so there is a lot of loss of latent heat of vaporization, and it can also lead to water overload. And with increased humidification, there is increase in the salt layer, size of salt layer, and this can lead to impaired function of the mucociliary elevators. And I'll show that in the diagram. Okay, so that's the diagram of the similar gel and salt layer. So now the water levels are increased. There is edema formation. The cilia are now fully immersed in the salt layer. And because they are fully immersed in the salt layer, they cannot actually move the mucus. So the mucus, the cilia usually beat towards the outside so that patient is able to expectorate. Okay, but if overhydration occurs, then the cilia will become dysfunctional. They'll just be floating in the water layers. So that's the whole thing. So if you look at humidifiers, the humidifiers can be very simple, like the heat and moisture exchanger or HME filters. You can have cold and hot water humidifiers. They are cascade humidifier. There are hot rod types humidifier where the gases are humidified within the breathing system. Then we also actually have Venturi or Bernoulli types or water jet types, ultrasonic nebulizers. But these are actually nebulizers, so you are directly instilling water into the airways rather than actually humidifying. In humidification, usually we tend to warm them up as well. Okay, that's what it is, because we know as the temperature goes up, then the capacity of the air to hold water increases. Okay. So ideal humidifier should be simple to use and simple to be serviced. It can be used with spontaneous as well as controlled ventilation, and it should have safety mechanism against overheating, overhydration, and electrocution. So it should have electrical safeties associated with it. And it should allow the inspired gases to remain sterile. Okay. So there should be no growth of bacteria within the waters which is being humidified or heated up in the humidifiers. That's the humidifiers. Okay. And inspired gases which are delivered to trachea should be at a temperature of 30 to 36 degrees. and have water content of around 33 to 43 gram per cubic meter. All right. So 43 gram per cubic meter is 100% humidity at body temperature. Humidification temperature should not be affected by the fresh grass flows, especially where high flows are used. And humidification be provided by any mixture of inspired gases. Obviously, in the intensive care, it's usually oxygen and air, but in the theaters, we tend to actually use air, oxygen, and nitrous oxide. So it could be oxygen could be mixed with air or with nitrous oxide. And resistance, compliance, and dead space should not adversely affect the spontaneously breathing patients. So there should be no increase in workup breathing when the humidifiers are used along with the breathing systems. Moving on to the third question. Third question is on TANs. Okay. How does it work? So it's used for pain management. So you should know it's a simple working principle. We're not talking about the circuitry of a TANs machine. We are just talking how it does it work physiologically. What are the indications of its use in pain management? What are the contraindications to the use of this modality of pain management? So the mechanisms of use of TANs is basically gate control theory, okay, which was proposed by Malzak and Wohl. Same theory actually is used with TANs. So when you apply the TANs using a pad to a body in an area, the current is slowly increased till you feel a kind of a tingling sensation, which the patient should be able, or yourself should be able to tolerate it. Okay. So this tingling will stimulate the large diameter afferent fibers, and this will then inhibit uh, the inhibitory processes in the dorsal horn of the spinal cord. And this is done both presynaptically and postsynaptically. So then on the right side, you can actually see a nice diagram. So there is this descending modulation, and there's also modulation of the gate. So in the dorsal horn, this gate is actually shut so that the transmission through C fibers or A delta fibers is actually reduced or stopped. There's also theory that maybe this also produces indigenous opioids by the stimulation. But if that's the case, then we should have been able to block it by giving naloxone, but it doesn't happen. Okay. So the activation of the descending inhibitory mechanism is probably the most sensible mechanism of action which we can be described to this modality. And the other is just a placebo effect, okay, because you are actually applying something for the pain, and maybe they just have acting. So it could be a bit of a placebo effect as well. So it has been used for both acute pain and chronic pain. So post-operative pain, abdominal, orthopedic, obstetric, and can say. It has been used for labor pain for quite a lot of years. So especially early stage of labor, Lactol are placed at T10 to L1 level. It has also been used for treatment for management of vaginal pain, and it is known to reduce the ST segment depression and help in the working capacity and tolerance to pacing in patients. In chronic pain, again, it has been used for a lot of many things. So it has been used for neuropathic pain, post-hepatic neuralgia, phantom limb pain, stump pain, peripheral nerve injury pain, complex regional pain syndromes, that is CRPS. It's used for low back pain, including nerve root pain, musculoskeletal pain, facial pain from trigeminal neuralgia, atypical facial pain, pain associated with malignant disease. So it's been used for both acute and chronic pain. So it stands contraindicated. Well, it's considered to be a safe mode of treatment of pain, but it is said that use of TANs can stimulate pregnant uterus, so better to avoid in the first trimester and only restricted to use in labor analgesia. Patient with cardiac pacemakers, it can be hazardous if it is actually used near to the pacing unit. So you could probably use it far away from the pacemaker, but that's better to actually use it far away from the pacing unit. And like I've said, it has been used for management of pain, chronic pain, trigeminal or atypical facial pain. So when you're applying it here, then stimulation of anterior neck can stimulate carotid sinus or the nose to laryngeal muscle, causing laryngeal spasm or causing bradycardia. So avoid using it in that region. Okay. So not very anything very serious side effect or contraindications for using TAS. Coming to fourth question is about substance use disorders or SUD. And so the first part is describe special consideration in the perioperative period assessment of alcohol abusing patients. So in the West, not a very uncommon thing. What are signs and symptoms of alcohol withdrawal? What is the difference between addiction, dependence, and tolerance? And how will you plan anesthesia for patient with history of substance use disorder? So a very crowded slide, but most of the things you would probably already know. So patients who abuse alcohol. So in cardiovascular system, these patients can actually present with tachycardia, dysrhythmias, cardiomegaly so may indicate alcohol-related cardiac dysfunction, and hence patients who have chronic alcohol use, they should actually get 12-lead ECG for all patients for evaluation. So alcohol-induced cardiac disease also leads to less sensitivity to endogenous or parental catecholamines. Okay, that means they would actually require a lot more of the vasopressors in case of hypertension. Uh, and then these patients, they are fluid depleted, and it's always important that before anesthesia, you do fluid resuscitation for these patients. So even if they have not had alcohol that day, normally would actually give them almost a liter of fluid before I induce anesthesia in these patients. Also, we talked about hypokalemia, and malnutrition is common in alcoholics. And because of that, they have very low glycogen storage in the liver, and their intake of the usual requirement for electrolytes is markedly reduced. So these patients can have hyperkalemia, hypomagnesemia, which is normally associated with hypokalemia. And they can actually go into hypoglycemia very quickly, especially if they've been fasted. So monitor their blood glucose and electrolytes. These patients can also present with anemia, thrombocytopenia, altered coagulation. But if these are present, then they usually indicate significant liver disease. Anemia can be because of nutrition deficiencies, but if thrombocytopenia and altered coagulation are present, then this actually indicates that there is a severe liver disease secondary to alcohol abuse. And if patients actually have a significant liver disease, they can develop portal hypertension, and these can actually then patients can develop esophageal varices. And so you need to be careful while putting an NG tube or transesophageal echocardiogram. If you're planning for that, then they need to be careful with that. So alcohol withdrawal can be present in patient acutely. These patients are anorexic, they have insomnia, weakness, and they can be aggressive at times. They may present with tremors, dilated pupil, they can be disoriented, may also present with hallucination, which can be auditory or visual. And in very severe cases, there can be convulsions, and these patients need to be treated properly. They need to be on the regimens. They need to be on vitamins. So onset of alcohol can occur within 10 to 30 hours after the abstinence has begun. So if they are admitted in the ward for during uh, the day before surgery, which is uncommon nowadays, but if they are admitted, then make sure that they are on a withdrawal regimen as per the hospital protocols. And the symptoms can last for as long as 40 to 50 hours. Prolonged abstinence can lead to delirium tremens. It can also lead to autonomic hyperactivity, which is present as tachycardia, sweating, fever, anxiety, and confusion. So, alcohol withdrawal syndrome can occur even under anesthesia, and you would certainly, even though you have given right kind of anesthesia, adequate analgesia, they can present with uncontrolled tachycardia, the sweating, hyperthermia. Okay. And treatment, obviously, in these cases is administration of benzodiazepines. So, what is dependence? What is tolerance? What is addiction? So, dependence is basically a state of adaptation that manifests by a drug class-specific withdrawal syndrome. So, there is withdrawal associated with dependence. So, like alcohol dependence will present as withdrawal. Okay. And this can be produced by if there's abrupt cessation, there is rapid reduction in dose, or there is decreased blood levels of the abused drug, or you administered antagonist against, okay, for the drugs, so like opioid. So tolerance is a state of adaptation, okay, that will induce changes that results in diminution of the effects of the drug over time. So for the same effect, you would need larger and larger amount of doses. So that's tolerance to the drug. So they may not get pain relief from the same amount of, say, opioid as you would get for that particular surgery in a patient. They would require a lot more than that. Whereas addiction is kind of more of a neurobiological disease, which is associated with genetic, psychosocial, and environmental factors, and it influences its development and manifestations. And you will see behaviors that include one of the following. They can be impaired control over drug use, right? And there's a compulsive use, or even continued use despite knowing that it can cause harm. And there is obviously craving there in addiction. So this is more of a neurobiological disease. So these are all are actually seen in drug use disorders or substance use disorders, SUDs, and even simple things like alcohol can lead to dependence, tolerance, addiction. Coming to anesthesia, obviously you need to know what drug the patient has been abusing, and so you need to have prophylaxis against physiological or physical withdrawal symptoms. So you would actually, for example, for patients who are alcoholics, they would actually need to be started on the withdrawal regimens, okay, which is basically based on chloride epoxide and with vitamins. Um, Pre-medication, you might need to use pre-medications like benzodiazepines in these patients with substitutes. In patients who are abusing opioids, in those cases, methadone would be required. And then you need to modify your anesthesia technique. So these patients might be tolerant to the opioids, and that's why regional anesthesia is important part of the anesthesia technique. You can use catheter techniques, or you can actually use just a single shot techniques, which can be followed up later on with the usual pain relief. Um, In certain cases, you might need to avoid succinylcholine, which can lead to rhabdomyolysis. Halothane is not used nowadays. It is known to cause hepatic damage. But most of the presently used world anesthetics like insulin, desferin, are all safe. You can use opioids that have kind of a slightly longer effect, like sufentanil, fentanyl, morphine, are acceptable, but you avoid remifentanil because it can induce post-operative hyperalgesia in these patients, so avoid remifentanil. But if you want to use TIVA using the propofol and remifentanil, that can be used, but make sure that before you stop remifentanil, you have adequate amount of morphine or fentanyl on board in these cases. Like I have said, in certain cases, use of antagonists can induce withdrawal. So if you can avoid neostatin, flumazenil, naloxone, then absolutely avoid it. You can use other regional anesthesia techniques like infiltration by surgeons, or like rectus sheath catheters by surgeons, or paravertebral catheters by surgeons can be used. And obviously, intravenous non-opioid painkillers, parts of multimodal analgesia. So using clonidine or alpha-2 agonists are good for preventing withdrawal. Use of paracetamol, intravenous non-steroidal drugs, use of magnesium, lignocaine infusions. These all can also be used in these cases. This is just a chart of equivalent analgesic doses of this. So you can look at the morphine is 1:1, whereas say somebody is using something like say codeine, 200 milligrams of codeine, that is equal to 1:7. So you need to actually give 7 times more. Some drugs may be a lot more potent, like hydromorphone is actually more potent than morphine. Oxycodone is slightly more potent than, oxymorphone is a little bit more potent than morphine. So knowing the analgesic doses are important when you want to substitute them with the IV doses. Next question is on the management of pain control for thoracotomy. And then the second part is discuss the advantage and disadvantage of epidural analgesia over intercostal blocks for pain control following thoracotomy. So if you look at modality of pain control, it can be classified into parenteral and regional anesthesia techniques. Parenteral opioid infusion, you can use patient control analgesia, or you can use infusions, you can use like IM doses, morphine, fentanyl, remfentanil. Then coming to regional anesthesia techniques, we can use epidural, intrathecal opioids, paravertebral block, erectospinal block, intercostal block, interpleural analgesia, cryoprobe, and neurolysis have also been used. Or you can use a combined technique where you can use parenteral as well as regional anesthesia techniques. So these are more of a balanced analgesic techniques. Okay. So if you're actually good at drawing diagrams, you can draw diagrams. You can start with central. So you can use intrathecal opioids or epidural analgesia. You can go a little bit more peripheral with paravertebral blocks or rectospinal blocks. Again, you can use catheters as well here. Then move a little bit peripherally. You can use intrapleural analgesia. You can do it preoperatively, or you can actually have the surgeon leave a catheter in there. And then you go a little bit more peripheral into the intercostal space. So you can do intercostal nerve blocks, or you can use cryoprobe neurolysis. And this leads to prolonged analgesia. And obviously there is regeneration, and pain can always come back. But then this is for acute pain, not for chronic pain purposes. So the advantage, obviously, of epidural is that here we normally use combination of local anesthetic and opioids. So there is segmental viability of opioids in the CSFs, and binding of the opioid to the mu receptors occurs. And this leads to blocking of release of substance P in the substantia gelatinosa of the dorsal horn. So utilizing only the thoracic segmental effect of local anesthetic opioids combination leads to minimization of motor and sympathetic blockade. So it's very local. So it's usually, even though it's happening on both sides, but then it is just restricted to that segment. So you don't see any effects on the motor or on the sympathetic blockade. There is sympathetic blockade with epidurals, but it's not minimal with the concentration of the local anesthetic we use for pain relief, so 0.125% BPK. And it allows patients to remain conscious, unlike where drowsiness can happen with IV opioids here, and patient can actually have good cough reflex so they can continue with their physiotherapy. And it produces reliable analgesia, which will help in their recovery, faster recovery. The drawbacks is that even in the best hands with thoracic epidurals, the failure rate is around 15%. And it can obviously be technically difficult. And it is because of the acute angulation of the spines. So people tend to use a paramedian approach in most of these cases. There may be theoretical risk of cord damage, but it's no larger. This has been discussed many times. There is a lot more space between the dura and the spinal cord in the thoracic region. And you can't send patients to normal wards. The patients need to go to wards where the staff is able to look after them, because if there are any complication associated with the epidurals, they should be able to recognize it. And there is obviously special charting of the vitals required, plus the pain charting is required. And you should also actually have rescue analgesia prescribed in case the epidural fails or epidural dislodged. So there should be a rescue analgesia. So sympathetic blockade is minimal, but it does occur, and it can lead to hypertension, especially in patients who are hypovolemic. And this might sometimes require you to stop the epidural infusion or even reduce it further. Some amount of motor blockade of intercostal muscles can occur, but it is not as much. But this can be problematic in patients who have low FEV1. And they're obviously contraindicated in patients who have local or systemic sepsis. For example, if the surgery is for decortication of an active empyema, then you may not be able to actually use it. Intercostal blocks, the advantage is that these are unilateral, so you can site the block to that area specifically. Single injection will cover 2 or 3 intercostal spaces. There is usually a little bit of spread, up and down the segment you use. Right? And because they are more peripheral, then the local anesthetic cannot diffuse to the sympathetic trunks. So there is no sympathetic blockade, which is seen with epidural. Disadvantage, you might need to use multiple level catheters. It can be time consuming, and it can be, complicated. If you're using, say, 2 catheters, then you need to actually have that attachment so that you can still use a single machine for infusing. You don't want to have 2 or 3 machines for infusing that. And there is a sparing of posterior cutaneous nerve, and hence there can be some amount of inadequate posterior analgesia can be seen. And you require much larger volumes of local anesthetic. And there can be absorption of local anesthetic as well, because this is a vascular space, and it can easily exceed the toxic limit sometimes. So that was the question number 5. And now coming to the last question of the day. So the question is about on liver. It briefly described liver anatomy under the following headings: gross anatomy, blood supply, microcirculation, and importance of knowing about the functional unit of the liver. Okay. So liver is one of the largest organ in the body. It weighs around 1.5 kgs. It's almost 2% of body weight in adults, and in children it can be as much as 5%. It also has high blood supply, so it is 25 to 30 ml blood per 100 gram of tissues, which amounts to 10 to 15% of total blood volume. In this, the 20% is in arterial system, 10% in capillaries, and 70% in the venous system. So this is a large reservoir for blood because it's a venous system. There's not active take, so it's a large reservoir of blood, like your spleen. And there is large, it's got a huge blood supply. It's almost 100 ml per minute per 100 gram, which accounts for around 25% of the cardiac output. For 1/4 of the cardiac output actually goes to the liver. So that is the gross anatomy. You don't actually have to describe the organ. Some of things which are related to surgical anatomy, especially when you're talking about liver transplant or you're talking about the hepatic resections, then you need to actually know this divisions. If you can do it in a simple way, that's fine. But so it's no longer right part or right hepatic. This is, the classification, which is known as Kuhnau's segments, and you should know how these segments are actually divided. If you look at it, they go clockwise, 1, 2, 3, 4, 5, 6, 7, 8 labs. So it goes clockwise and the division. So you should actually also know this classification for surgical purposes or for transplant purposes. So if you look at the blood supply to the liver, it is coming from the celiac trunk. And so the celiac trunk gives rise to the hepatic artery. But a lot of the blood which goes to stomach, spleen, pancreas, small intestine, written back via the portal vein to the liver through the sinusoids, which then drives via the hepatic veins into the inferior vena cava. Okay. So the hepatic artery, which is a branch of celiac axis, like I've said, this accounts for 25 to 30% of the total hepatic blood flow, which is around 500 ml per minute. And it supplies around 40 to 50% of the oxygen supply comes from the hepatic artery. Portal veins, which are draining from the stomach, spleen, pancreas, intestine. These are valveless afferent nutrient vessels to the liver. And they supply 70 to 75% of the total hepatic blood flow. But only because it's a venous blood, so they only account for 50 to 55% oxygen supply coming to the liver. So when you look at the microcirculation, and the functional unit of liver is actually acinus. Okay. And we will actually look at it, the various zones which are divided depending on the blood flow. And you can see the blood flows occurs from the portal triad to the central vein. And from the central vein, the blood actually drains via the hepatic vein into the inferior vena cava. So you should be able to draw these diagrams. So you got the portal triads, and it's like a hexagonal with the central vein. And around the central vein to the portal triads, now where you actually have the bile duct, portal vein, hepatic artery, they are divided into zones 1, 2, and 3. So obviously zone 1 has got the maximum amount of the blood flow, and zone 3 has the least amount. And because of this, we will actually discuss that, how knowing the liver acinus as the unit of liver is important. So in zone 1, hepatocytes are close to the portal axis, Origin of the sinusites are bathed in blood that is rich in oxygen and nutrients. Whereas we look at zone 3, which is near to the your vein. So let me go back here. So if you look at this, the central vein, okay, so that's zone 3, which is very close to the central vein. So the cells are situated periphery of the acinus, near to the central vein, and they receive blood that has already exchanged gases and metabolites occurring in the zone 1 and 2. And zone 2 is sort of arbitrary between, or it's intermediate between the zone 1 and zone 3. Okay. So cells in zone 1, they contain lots of mitochondria, and they're ideally suited for the oxidative metabolism and synthesis of glycogen. Whereas in the zone 3, the biotransformation of the majority of drugs, chemicals, toxins occur in this zone. And this is because they have huge amounts or large amount or abundance of smooth endoplasmic reticulum, and they have the NADP and cytochrome P450 as large amounts occur seen in zone 3. So cells of zone 3 are most sensitive to damage from circulatory disturbances like ischemia, hypoxia, and congestion. You'll see central vein necrosis, okay, and injury by toxic byproducts of biotransformation. Again, the injury actually is seen in zone 3. Okay. So drug biotransformation will be compromised early in the ischemic injury, and this is seen in zone 3. So that's the importance of actually knowing the functional unit of your liver, that is the acinus. Okay. So the next session will be on 24th of November. I think we'll probably be doing it at not at 5:30, but around 6 o'clock. And that is 12:30 at the GMT. Okay, so we'll see you next week with another 6 questions. And I'll try to post these questions again on the group. Thank you very much, guys.